Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 34. We'll be talking about positive sense RNA non-envelope viruses. Specifically, we're going to talk about calicivirus, picornavirus, the enteroviruses, and rhinovirus. The enteroviruses have a number of viruses in their family which cause human disease. We'll talk about hand, foot, and mouth disease and the common cold. We'll go through slowly so you can pay attention, and these will be frequently tested on Step 1. Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 34. We're going to talk about positive sense, non-enveloped viruses. The table on this page highlights the positive sense RNA viruses and their characteristics. This, like the other tables, is important to be familiar with. You should remember that calicivirus and picornavirus are naked viruses, and that you should be familiar with the diseases each family of viruses causes. RNA non-envelope viruses include picornavirus and calicivirus. In the picornavirus family, you have to worry about enterovirus and rhinovirus. In calicivirus, you worry about Norwalk virus. Picornaviruses are small, non-enveloped, icosahedral nucleocapsid viruses. They're single-stranded with positive sense RNA, and they replicate right in the cytoplasm. The protein on the 5' end serves as a primer for the transcription by the host RNA polymerase. Enteroviruses replicate optimally at 37 degrees centigrade. They're stable in acidic conditions and they can live in our GI tract. Rhinoviruses optimally replicate at 33 degrees centigrade, which are a little bit cooler, and so they like our respiratory tract, and they're acid labile. Enteroviruses include poliovirus, echovirus, Coxsackie A and B virus, and hepatitis A virus. And the transmission is usually fecal-oral. Enteroviruses are the leading cause of aseptic or viral meningitis. They primarily affect infants and young children, and you diagnose them with real-time PCR. You can do a CSF culture, but it's only sensitive about half the time. Stool culture you can find shedding, which may continue for weeks after infection. So here's a question. A 21-year-old male develops abdominal pain, diarrhea, and dyspepsia. Then about a week later he gets a headache, vomiting, and fever. Spinal Tap reveals CSF with high cell count and protein consistent with viral aseptic meningitis. The most likely pathogen? So we have here, a viral meningitis after an abdominal infection. Mumps doesn't typically cause abdominal infections, although it can cause aseptic meningitis. Echovirus we haven't talked about, but is unlikely to cause both abdominal and meningitis. Enterovirus will do both, and it'll do a good job. Rhinovirus, again, we think of upper respiratory tract infections rather than GI. Pathogenesis includes infection of oropharyngeal mucosal cells and lymphoid tissue. Then it replicates, sheds into the alimentary tract, passes into the intestine, infects the intestinal mucosa and lymphoid tissue. Then you get a secondary viremia and an immune response. Most of the clinical findings are minimal. You get asymptomatic disease, you can get fever and generalized malaise. Diagnosis is difficult for symptoms alone, and so you look for epidemiology. If there's a group or an outbreak of these, it helps with the diagnosis. Poliovirus has a variable outcome infection. You can range from asymptomatic to paralytic poliomyelitis. Clinical findings in poliovirus include, like I said before, asymptomatic disease. You can also have abortive poliomyelitis within the first week. You get general malaise. You may or may not have vomiting, headache, and a sore throat. Then you get, a few days later, non-paralytic poliomyelitis, where it spreads to the brain and meninges, and you get a stiff neck and vomiting. Within 4 days, you get paralytic polio, where it spreads from the blood to the anterior horn cells, and it's important to remember that it's the anterior horn cells which carry the muscle fibers. Or you could do motor cortex of the brain, which is involved. A post-polio syndrome may happen any time later, where you get further loss of muscle use. Paralytic polio is the most feared complication of poliovirus. The virus destroys the presynaptic motor neurons in the anterior horn cells, as well as the postsynaptic neurons. This is heralded by a recurrence of fever and a flaccid asymmetric paralysis, hemiplegia, paraplegia, quadriplegia, and respiratory muscle dysfunction. You can also get painful muscle spasms and asymmetric muscle paralysis, ultimately leading to atrophy and loss of reflexes. Unfortunately or fortunately, you have no sensory losses. It's all muscular. Question. A 6-year-old male was admitted to the emergency room with a fever, headache, stiff neck, and photophobia. A few days prior to admission, he complained of weakness in his lower extremity and left arm. LP reveals lymphocytic pleocytosis with normal protein and glucose levels. His immunization history was questionable. Stool cultures revealed non-enveloped single-stranded positive sense RNA virus that was acid stable. The most likely pathogen? So we have something that he should have been immunized against, which is causing him to be weak and have photophobia and cause meningitis. You worry about poliovirus. It's the positive sense RNA virus that's acid stable. Calicivirus is also acid stable and positive RNA. Reovirus and Toga virus are not. Calicivirus, however, is not going to cause this. Prevention. There are 2 vaccines for polio available. Initially, you had the Sabin vaccine. It's a live attenuated virus. It's administered orally, so you don't have to have a shot, but there is a risk of revertant disease. The Salk vaccine is the one that's more recommended now. It's killed virus. It can't get you sick, and you have to inject it. Question. Which of the following statements concerning viral vaccines is correct? A. In live attenuated vaccines, the virus retains its ability to cause disease. That's not correct, or else we wouldn't give it to people. B. In live attenuated vaccines, reversion to virulence is of no concern. That's not true. We saw that with the oral polio vaccine, and so that's why we don't give it as much. C. With killed vaccines, mucosal immunity is induced. That's not true. The killed vaccines are injected and they get a more systemic immunity. And D. With killed vaccines, protective immunity is usually IgG. That's true. It's long-lasting and gives memory, which is why it works. Question. During a WHO inspection of facilities in Pakistan, a small capsid virus was isolated from poorly processed sewage. Which of the following viruses may have been isolated? A. Hantavirus, B. Measles virus, C. Poliovirus, or D. Varicella virus. Well, the things that are going to last in sewage and be able to be a small capsid virus is going to be poliovirus. None of the other viruses really apply here. Coxsackie virus. Type A usually causes surface rashes or exanthems. It can cause mild respiratory symptoms. It can also cause aseptic meningitis, herpangina, hand, foot, and mouth disease. Type B is more for body. It causes internal symptoms such as pleurodynia, myocarditis, cardiomyopathy, and heart failure. It can cause some mild respiratory symptoms and aseptic meningitis or diabetes. Clinical findings. These are prevalent in the summer and fall. They are a common cause of aseptic meningitis and headache, stiff neck, fever, and generalized malaise. Herpangina is usually Coxsackie A. You get fever with painful ulcers on the palate and tongue, and you have problems with swallowing and vomiting. Myocarditis is Coxsackie B virus, not Coxsackie A. You get fever and chest pains, arrhythmias, and you can even get cardiac failure. Bornholm disease is pleurodynia, or the devil's grip, with Coxsackie B, characterized by fever, sudden sharp pains in the intercostal muscles, plus or minus abdominal pain and vomiting. Question. Several children in a daycare center developed fever, headache, sore throat, followed by vesicular eruption of the buccal mucosa and polyps. Similar vesicular lesions were also seen on the hands, feet, and diaper area. The most likely pathogen is. So this is a good description of kind of hand, foot, and mouth disease. It's commonly spread by fecal-oral transmission. A daycare center is right where it's going to be, and you're going to have the fever, the sore throat, and then these sores on the hands and the feet and the mouth. Okay? Coxsackie A virus is the definition. Next question. A 35-year-old company executive complained of fever and sharp chest pain. He developed a viral upper respiratory infection with fatigue and a runny nose and malaise a week ago. His chest pain over the last 24 hours has worsened. It's aggravated by deep breathing, coughing, and laying flat. The pain is relieved by sitting up and leaning forward. Clinical exam is also remarkable for pericardial friction rub. The EKG has characteristic diffuse ST segment elevation. The most likely pathogen is. So in this situation, we have a youngish guy who had a viral infection, and now it sounds like he has pericarditis. It's better when he leans forward. He's got a pericardial friction rub. Coxsackie virus B is common to cause pericarditis, especially after a mild upper respiratory tract infection. Influenza, herpes, and adenovirus are not going to cause pericarditis. Rhinoviruses are the main cause of the common cold. There's over 100 serologic types. They replicate better at colder temperatures like 33 degrees centigrade. They're acid labile and they bind to ICAM1. Transmission is person-to-person aerosol spread of respiratory droplets. You can also get indirect transmission, droplets deposit on surfaces. Then you get fingers and then you put them in your nose or in your eyes and you get the rhinovirus that way. Clinical findings include an incubation period of 2 to 4 days, in which case you can spread the virus to other people. You get sneezing, nasal discharge, sore throat, cough, headache, and it usually lasts about a week. Everybody's had a cold. Coronaviruses are positive RNA and they're enveloped. They're unlike other enveloped viruses and they're able to pass through the gut. They're the second most common cause of the common cold. They can also cause SARS, sudden acute respiratory syndrome. SARS is associated with the coronavirus. It's highly contagious, it has a short incubation period of 2 to 10 days, and a mild viral illness progressing to severe dyspnea and hypoxia. It has a 3% mortality. Diagnosis is by ELISA or indirect fluorescent antibodies. You can also do RT-PCR of serum and nasal secretions and stool to isolate the virus. You can use ribavirin for treatment just like you do for RSV. Other viruses causing respiratory infections include influenza, which can cause a tracheobronchitis, parainfluenza, which is a common cause of croup or laryngitis, RSV we talked about causing bronchiolitis, adenovirus causes pharyngitis and conjunctivitis, enterovirus can cause herpangina or oral ulcers, hand, foot, and mouth disease. Uncommonly, you get HSV, CMV, VZV, EBV, or measles. Reovirus's most important member is the rotavirus. You can also have the cultivirus, which used to be called orbivirus. Rotavirus causes prolonged childhood diarrhea. It's a double-stranded RNA virus. It's segmented, non-enveloped, and icosahedral. It has a double capsid. It looks like a wheel, and that's why they call it rotavirus. Transmission is person to person through the fecal-oral route. You can get it through fomites, by food and water, or through the respiratory route. Rotavirus is introduced into the GI tract, and it has protease which digests and removes its outer capsule. The attachment is mediated by the inner capsule. Remember, it has a double capsule for rotavirus. Viral propagation happens within the cell, causes cell dysfunction and death. The cell is lysed, and you get secretions of intestinal fluid and a watery diarrhea. Clinical findings include a high-grade fever, nausea and vomiting, and that leads to dehydration. You obviously get diarrhea that can last 3 to 9 days. It's very, very common in kids and can be a serious problem worldwide. It's a big cause of infant mortality in the developing world. It usually happens in the winter months. Complications include necrotizing enterocolitis, hemorrhagic gastroenteritis, and you can find that in neonates. Lab diagnosis is by antigen detected in the stool by ELISA. Treatment is mostly supportive. There is an oral vaccine which is monovalent or pentavalent called Rotarix, and these are reassortment viruses and so they can avoid vaccination immunity. Other causes of viral gastroenteritis include astrovirus, which is a positive single-stranded RNA. It has 7 types. It's most severe when you're less than 1 year old, and it has a 2-day duration. You'd have to diagnose it by electron microscopy. Calicivirus, the prototype there is a Norwalk virus or the norovirus. It also is positive single-stranded RNA, non-segmented, with no seasonality. You'll see it often on cruise ships with contaminated water and shellfish, and you have to do PCR. Adenovirus is a double-stranded DNA which causes diarrhea, which is milder than rotavirus, has no seasonality, and it's types 40 and 41. Again, antigen detection by PCR for diagnosis. Question. An outbreak of gastroenteritis characterized by nausea, vomiting, and water diarrhea in a daycare center is most likely to be caused by which of the following viruses? When you have children in a daycare center with gastroenteritis, you want to think about rotavirus, and that's the answer. Which of the following statements regarding rotavirus is false? A, it's an envelope virus. We know that's not true. Most of the viruses which cause gastroenteritis are non-enveloped, so they can stay in the gut, they're acid resistant, and they can live for long times in the stool. It is double-stranded and has a segmented RNA genome. The genome is within a double-layered icosahedral capsule, and it has its own RNA-dependent RNA polymerase. All those things are true. Wrapping up Module 34, we talked about the positive sense RNA non-envelope viruses. Enterovirus is an important clinical family in this group. Specifically, you have poliovirus and Coxsackie viruses. Rhinovirus is also important as the causative agent of the common cold. With poliovirus, it's frequently easy to get this from the clinical picture of somebody who comes in with a paralytic disease after a viral infection. You also worry about the Coxsackie viruses. They can cause a myriad number of diseases. Remember, they can cause pericarditis, encephalitis, meningitis, and in addition to the hand, foot, and mouth disease. We also talked about rotavirus, one of the world leaders in infantile and childhood diarrhea. It's important to remember that these viruses can act just like mRNAs because that's what their genome is. Be familiar with their replication strategy and how they get in and out of the host, and they don't require an envelope from the host. Next up, we're going to talk about the hepatitis viruses in Module 35.